Hello, my name is Leo Smythe, and this video is a primer on how I think POCUS should be used effectively and responsibly when trying to solve clinical problems. I've made this video with the support of Brian Buchanan and Alberta Sono. I'll start with my disclosure, which are none other than I think POCUS is a powerful adjunct to the clinical assessment. From an objective point of view, I just want to review some of the cognitive biases for clinical decision making, illustrate some potential biases and pitfalls of POCUS, and demonstrate a strategy for optimizing the integration of POCUS into clinical decision-making, which brings me to the spoiler. POCUS is an adjunct to the clinical assessment, and it does not replace any part of the clinical assessment. If you're watching this, I don't need to tell you that point-of-care ultrasound has an amazing ability to improve the accuracy of diagnosis, expedite the time to diagnosis, expedite the time to treatment, and potentially avoiding the pitfalls of ionizing radiation and system costs. All of these things make you, your patients, and the system very, very happy. But I will tell you that with great clinical power comes the great challenge and responsibility to use POCUS wisely. Let's start with a case so I can show you what I mean. So you're on an ICU outreach team and you're assessing a 64-year-old male inpatient who has acute onset hypoxia and hypotension. The history is significant for a lung transplant a few months prior as a treatment for end-stage pulmonary fibrosis. Now pause. Where did your mind just take you? I bet you just started your approach to hypoxemia and hypotension with extra consideration for this patient's complexity. Our clinical training has taught us to structure our thinking, these types of situations, some version of sick, not sick, immediate management, movie, IVO2 monitors, come up with some sort of differential, sort it by severity probability, come up with some high yield investigations. Now, when thinking about potential etiologies, how did you develop this list? Did you A, reflexively recall your hypoxemia panel and hypotension panel? Did you B, recall a structured, comprehensive approach to the differential and built a list of your history of physical investigations that will help you differentiate them all? Or did you combine the two? Most of us would probably do a mix of the two. Why does this matter? Clinical medicine is tremendously complex, and our mind just cannot integrate every piece of evidence and missing clinical information precisely and quickly. We're not computers. A leading theory of clinical reasoning describes System 1 and System 2 model. The System 1 model is driven by pattern recognition. It uses heuristics, such as illness scripts, to rapidly sort and prioritize clinical information. In our case, recalling your initial hypoxemia investigation panel would be an example of this type of thinking. It's efficient and especially effective when there's time pressure or complexity and diagnostic uncertainty. However, this method is prone to error and neglects a systematic evaluation of the case. System 2 thinking is critical, deductive, and deliberate, as clinicians were taught to work through a case in this way. Remember Bayesian Statistics? With pretest probabilities, likelihood ratios, as well as nomograms to get you around this impossibly difficult mental math. Highly structured clinical thinking methods such as this are slow, laborious, and require significant cognitive as well as clinical resources. However, since this process is very structured, clinical decisions are typically accurate and complete. Generally, a blended model where heuristics are used to first sort clinical information, which can then be evaluated analytically to develop a prioritized differential, is the way to go. Diagnostic problems arise, though, when we don't use these two methods together, and it almost always stems from unrecognized biases or cognitive shortcuts. There are dozens of unrecognized biases and errors that clinicians are susceptible to. This is a short list of some of the common ones, and while most of us don't think about them every day, I'm sure you've come across them in your practice. I know I have. So could POCUS eliminate all these biases, or does it exacerbate them? While we ponder this, let's get back to our case. We left off with our initial cognitive approach. This patient was very sick and was transferred to ICU for oxygenation and vasoactive medications. Additional history suggested that this patient had been stable and had been progressing well with physio, and the team was planning on getting this patient discharged in the next few days to a week. He did not have any symptoms suggestive of infection or pulmonary embolism or pneumothorax. In fact, nothing seemed out of the ordinary. He had a prior aspiration event, but had passed a swallowing study earlier this week, and he hadn't had any witnessed symptoms of aspiration. The day before, he had an episode of hypotension that was noted, and overnight they had to increase his O2 requirements up to about 5 liters. He was kind of intermittently on oxygen at baseline. The physical examination was quite striking. His blood pressure was low in the 60s over 40s. He was tachycardic. He's hypotensive, requiring a high-flow nasal cannula in order to support him with vasoactive support. Pulmonary exam didn't show anything convincing other than dullness at the bases without much by the way of crackles or wheezes. His heart sound seemed normal. His abdomen was soft and tender. There wasn't a sacral ulcer, signs of a DVT or cellulitis. Arterial blood gas showed hypoxemic respiratory failure without significant hypercarbia, and his blood work was otherwise unremarkable. If you're wondering about pulmonary embolism, I am too. I would argue he's a bit too unstable to get to the CT scanner though. So what do we do next? This would be a great POCUS question, eh? So as we wheel the machine to the patient's bedside, let's think about what our approach to POCUS would be in this situation. To do this, let's think about the ultrasound examination just like you think about any other parts of your history, physical, or investigations. The first step is what's the differential diagnosis? And really, can ultrasound help me evaluate any of these? If they can, which findings are actually going to be helpful? Are there going to be confounders that I can expect? And do I really think that any of these findings will change my management? If we think about this patient, what would a reasonable differential include? I'd say there'd be lots of things. There can be some lung issues, such as acute rejection, pneumothorax, maybe a PE or pneumonia. There could be some cardiac issues, such as new presentation of heart failure, maybe some effusion or tamponade in the post-op setting. You could have an acute valve problem. And there's lots of potential sites of infection, including maybe the blood or a valve, a sacral ulcer, a UTI. Perhaps he still has some indwelling lines. Or maybe there's some zebras, like adrenal insufficiency driving something like this. I would argue that the most concerning etiologies, based on their pretest probabilities, would look something like this. Pulmonary embolism and pneumonia in a post-transplant patient would be quite significant. Things like rejection, heart failure, pneumothorax would probably be less likely. But don't forget that there are etiologies that you can't evaluate with POCUS. Anyway, let's start scanning. What findings would be helpful to look for, say, a pulmonary embolism? Well, cardiac ultrasound would be helpful to look for signs of RV strain, and the lower limb compression ultrasound would be helpful to look for a DVT. So let's look at the heart. How is the RV size compared to the left? Is the free wall moving well? What about the septum? Is there a D-shaped septum? I'd say there's no gross RV dysfunction. Before we jump to conclusions, let's do a compression ultrasound of the lower limbs. Say we start at the femoral vein, at the saphenous vein junction, and we work distally to past the bifurcation as far as we can, and then we compress the popliteal veins, and we do this on both legs, and everything looks like these pictures. So is there no DVT, and can we rule out a PE? After a quick review of the numbers, cardiac ultrasound and compression ultrasound are shockingly good for looking for venous thromboembolic disease. And since we didn't see any RV dysfunction or lack of compressibility, I guess we can pretty much rule out a PE or DVT, right? What was our pretest probability again? Could there be any confounders in this patient? I would argue that a post-op hospitalized patient with limited mobility and acute onset hypotension hypoxemia has a pretty high pretest probability of pulmonary embolism. I'm not sure I'd be confident ruling it out just based on looking at the heart on ultrasound. In fact, I would actually argue that cardiac ultrasound on its own cannot rule out a PE, but it could make it much less likely. But what about a DVT? Let's say we had a 80% pretest probability of there being a DVT in this patient, and we had a negative ultrasound scan, which has reported to have a likelihood ratio of 0.04. That would give us a post-test probability of 20%. A PE is a pretty big deal in a patient that's this sick, and anticoagulation is also a big deal in a post-op patient. So is 20% a low enough post-test probability in order to be actionable? What if I muddy the waters a little bit more? If you think back to those evidence tables in the JAMA Rational Clinical Exam series, do you remember how much variability there was between the likelihood ratios for the history and physical exam finding? They were often quite wide. There was a lot of variability, which makes sense. Patients and their clinical contexts are all unique. So you take the JVP, for instance. Are we equally confident that we can see it in every patient? I don't think so. Some patients have very thin necks, and we're very confident, and others have very large necks, and we wonder if there is even a vein up there. So if you think about it, why would POCUS be any different? There's lots of technical and cognitive factors that could really cloud the significance of each finding. The key message is that POCUS is not diagnostic imaging. The vast majority of POCUS accuracy data is developed from clinical situations where an appropriate history and physical have already been done. Therefore, the interpretation of POCUS is heavily dependent on your pretest probability. Also, remember that POCUS happens to be a bedside test and is rarely performed under ideal clinical conditions, making the accuracy very dependent on the patient and their context. So, POCUS is an adjunct to the clinical assessment. Thinking back to our patient, do they have a PE? Well, I think these findings make it significantly less likely that they have a PE. I don't think I'd be willing to rule it out altogether. What would be really helpful is finding another explanation for this patient's hypoxemia and hypotension. So, thinking back to our differential, lung ultrasound would be really helpful in looking for interstitial syndrome, suggestive of rejection or heart failure, or potentially lung sliding for a pneumothorax. Could this patient have a pneumothorax? These two clips are the right and left anterior chest, and here we can see the pleural line sliding. The chest x-ray did not show any evidence of a pneumothorax, so I'd say I have a pretty low pretest probability there being one. And sliding across the anterior chest would be very reassuring. Of course, sliding on lung ultrasound really only rules out a pneumothorax at that site. So if you're very suspicious, you need to look everywhere and look very carefully. Also keep in mind that a post-operative thoracic surgery patient may have some post-op adhesions, and lack of lung sliding may not represent a pneumothorax. Be careful of these types of pitfalls. Could our patient have interstitial syndrome? Interstitial syndrome is characterized by B lines, which are hyperechoic or white lines that shoot downward from the pleural line like jets coming from a rocket ship. Interstitial syndrome can represent many different pathologies, including cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, interstitial fibrosis. Clinical context is obviously very important. Our patient didn't have any B lines anteriorly or over the posterior thorax either. This makes cardiogenic or non-cardiogenic pulmonary edema very unlikely. What about pneumonia? Well, it turns out that both lung bases are hepatized. Here we have a nice shred sign, which is the interface between consolidated lung and aerated lung. There's also a small pleural effusion hiding here above the diaphragm. On the left lung, we can see a small pleural effusion here, dense hepatization or consolidation, and here we actually have an air bronchogram, which is air trapped in the distal airway, surrounded by consolidated lung. I'll just remind you briefly what the chest x-ray looked like. Okay, so putting all of this information together, I would argue that pneumonia in a frail, immunocompromised, hospitalized patient becomes the most likely diagnosis by far. Other diagnoses, such as pulmonary embolism, becomes much less likely given the alternative explanation and the lack of supportive findings. However, I could envision many clinical situations where I would still be suspicious enough of a pulmonary embolism in a case like this to start anticoagulation while waiting definitive imaging. In fact, this patient ended up being treated for hospital-acquired pneumonia, and sputum and blood cultures quickly grew Pseudomonas. After about 24 hours of appropriate therapy, suppressor support, he was able to be weaned, and his O2 requirements gradually fell. It's really important to remember that POCUS can augment clinical reasoning by providing instant, powerful clinical data that can expedite diagnosis and appropriate therapy. However, POCUS can also undermine clinical reasoning. In select circumstances, the binary findings of POCUS can seduce even the most vigilant clinicians. While the decision over the presence of a problem may be as simple as yes or no, for example, ascites or compressible venous system, inappropriate integration of these findings into the clinical context has the potential to short-circuit the sequential nature of clinical reasoning, and this can cause errors. So if you think A to B to C to D was hard, try getting from F back to C, especially if you took a wrong term off a bridge. Remember to be systematic, question yourself, and look at the whole clinical picture. Once again, I'd like to thank Dr. Brian Buchanan and Alberta Sono for their support with this project, and I thank you very much for listening.